Hi, and welcome. Thank you for joining us today for our second event in Talks with Texas 4000 for Cancer, Affording Access, as well as our morning ride. So just to introduce who we are, Texas 4000 for Cancer is an 18-month leadership development program that recruits students at UT Austin, many of you whom you'll get to see riding this morning. And traditionally, each of us fundraises $4,500, as well as volunteers 50 hours in our community and bikes over 2,000 miles in training in preparation for our Keystone event, which is a 4,000-mile bike ride from Austin, Texas to Anchorage, Alaska. And so for the first time since the founding of our organization, we will not be biking from Austin to Alaska this summer. Due to the threat that the current pandemic poses to the general public, as well as specifically the cancer community, we have made considerable adjustments to the physical summer ride to protect those that we hope to serve. And so as such, we are continuing to engage with communities such as yours in this virtual environment. And so because of that threat that the pandemic poses to the cancer community, we are continuing the fight at home the best we can. And so just to introduce this event, had we not canceled the ride this summer, Ozarks, the 2020 Ozarks team, would have visited Be the Match last week in the Minneapolis headquarters. And so in honor of that, we partnered with them last week to talk about healthcare inequity on the bone marrow registry. And so as we were planning for that event and as we learned more about healthcare inequity in the cancer community, we were inspired to create this 3-part series on healthcare inequity and accessibility within cancer, which we titled Talks with Texas 4000. And so today we're here to talk about affordability of cancer, affording access, and what that means, both in terms of the financial burden of cancer, as well as other hurdles to accessing care that are less visible and less tangible. And so today we have some really exciting things for you. We're going to have a short talk on kind of the nuts and bolts of healthcare inequity in cancer, as well as a representative, Arianna Anaya from the Foundation's Community Prosper Center. Very excited to hear from her today. As well as 2 of our teammates, Nikki and Anna L., who will have a conversation on the experience of marginalization in healthcare. But before we start with that, we'll start this broadcast as we start all of our Texas 4000 events with ride dedications. And so we're briefly going to show you a quick video on what those are.
Texas 4000 is the largest annual charity bike ride that takes place every summer from Austin to Anchorage, Alaska, with the purpose of spreading our mission of hope, knowledge, and charity in the fight against cancer. A ride dedication is a way that we start a lot of our meetings or a lot of our rides. This is when we dedicate a ride or a part of our ride to somebody who has been in some way affected by cancer.
A ride dedication is motivation to me, because when I'm going up a steep hill or it's been a really long ride, the ride dedications that I hear from my teammates and myself are the reasons that I keep riding.
Due to the current circumstances surrounding COVID-19, it's no longer safe for us to do our typical bicycle ride from Austin, Texas to Anchorage, Alaska. So instead, we've decided to do things virtually this summer.
So we will be having our cycling events virtually. We will be engaging with our community virtually.
A virtual ride dedication works largely the same way as a normal ride dedication. Before every meeting or before every virtual ride, you would say, I ride for this person. And if you want to, you can go into a little bit more detail about how that person touched your life.
You can submit your ride dedications via 3 different platforms. You can submit a ride dedication via the Texas 4000 webpage. You can join our Facebook live stream, or you can join our Zoom calls.
The virtual ride will be going on from May 29th to June 26th, and ride dads will be held before host interactions in the afternoon and at 7:30 to 8 a.m. Central Time every morning.
Thank you so much for participating.
Join us at texas4000.org. Together we can make a difference.
All right, so we'll welcome any ride dedications from our audience today. If you have any, just pop them in the comments, and we will honor those who are fighting and those who are in the fight against cancer today. Yeah, so to get us started, I would like to ride today and dedicate this event as well to those who are on our team whose family members are suffering from cancer right now, who very much are, and I'd like to ride for his strength as well as his mom's strength.
I have one as well. My name's Claire. I'm also on the programs team and the Ozarks route with Alex. But today I'm thinking of a close family friend named Chase. This coming weekend would have been his birthday, and every year there's an annual run in his honor, and that's not happening. Well, it's happening this year, but it's virtual, as most things are. And so just thinking about him and his family right now.
As always, I'm writing for Camp Kesem, which is an organization at the University of Texas at Austin that provides support services for kids whose parents have cancer. Every year over the summer, we have a 1 week long summer sleepaway camp in order to, get these kids their minds off of their parents' cancer and kind of help them deal with the grief that they're experiencing, and kind of explain to them, what's going on, and get them to communicate with other people who are going through similar situations as them. But unfortunately, because of the COVID pandemic, the camp isn't happening in person this year. We're also doing a virtual at-home camp. So still writing for them.
Absolutely. And always writing for especially children who are coming to terms with cancer and loss from cancer. Absolutely. I also would like to ride today for a good family friend and family member of mine who has been suffering from lung cancer for the past couple of years and has been able to get into clinical trials, and those have been very successful for him, CHIPS. And so very grateful that both the timing worked out for him, that he was able to be in clinical trials, and that they've been successful for him. That advancement in cancer care really is so incredible. And I'm so grateful that he's been able to participate in that, and even just had the extra time with his grandkids. And my great aunt has been so wonderful to see. Yeah, and here are our riders today that are riding with us from the Sierra route. Welcome, riders. It's great to see you here. Yep. They're riding today for this event, as well as for all of those who we ride for. Awesome. Do we have any from our... Oh, yes. Thank you, Katie. We'll definitely be riding for John Burnett today.
That's awesome.
Oh, so kind.
It's amazing how many people we've interacted with like that who are annual donators to the first riders they see that fall or that spring.
Just feel so connected to the mission that we do get to make those connections with people that you wouldn't really meet otherwise, which is something that's really quite beautiful about this organization, is those connections as we share our mission. Thank you, Tony. We'll definitely be riding for Robert and Teresa. It's good to see you here, Christiane. Thank you, Sharon. We will be writing for Karen. It is amazing the advances we've had in cancer treatment just in the past couple of decades. But that experience is amazing to be able to have your child survive cancer. Yeah, writing for Karen and the fight that she and her children had. Okay. So we'll definitely continue taking those throughout the rest of the event. You can always pop them in the comments, and we'll throw them on screen to honor your family members, loved ones, and friends. Yeah, we could transition into our next talk.
Yeah, so first, to kick off today's event, Alex and Yash, my lovely co-hosts, will be giving a quick presentation to talk about exactly what healthcare inequity looks like, as well as share some resources for those who are viewing.
All right, and do we have those slides prepared? Awesome, cool. Great, yes, thank you so much for joining us today again to talk about healthcare inequity. We're grateful to have you here. And we're excited to talk about what it means to access care. So we wanted to talk briefly about some of the hurdles of receiving adequate care, as well as some of those hurdles to even positive outcomes in cancer care. And so I wanted to share a story that I heard a few days ago with a program that we had with Putica Baptist Health with Dr. Reese and his team there. On Friday, he told us a story of a patient he had who was unable to cover the cost of his care, which was $3,500. And so resigned to that fate, because he was unable to cover the cost of that treatment, he began asking about hospice and his options moving forward. But because of support services like those that we're able to fund with Texas 4000, he was able to pursue treatment. He was able to continue his fight against cancer the way that he wanted to. And so that's something that's truly incredible about Texas 4000, that we don't just grant out to research, which is really important to pushing forward cancer treatment for the future, for those who will be diagnosed in the future. But we also fight for those who have it now. We give a fighting chance to those who have it now and those who are currently suffering. But it is truly sobering to me that a person's income or status within society could dictate their ability to even seek care, regardless of whether or not they want it. And so while support services have the power to shape the lives of individuals in a really beautiful way, it truly isn't enough. I fervently believe that your income or your insured status, much like your ethnicity, the color of your skin, should never determine your outcome in cancer. And that's something that we'll talk about today, because in a lot of cases, they do. So next slide. So I really wanted to share this graphic. I came across this about a year and a half ago as we started kind of learning more about cancer in the States, and especially as I was considering which route I wanted to be on with Texas 4000 and which part of the country I wanted to go through. And so I learned about the cancer belt. And this graphic is created by the CDC. As the stats are updated up to 2018, which is it's quite cool. It's a live graphic. And as you can see, there is a much higher mortality rate in this red region, right from Texas all the way up into the north. It's just a belt across the United States. And this has been called the cancer belt, where we have a much higher mortality rate. And so when I thought initially when I saw this was, well, maybe there's a higher density, maybe those states that have a much lower mortality rates because there's not as many cases, right? But this graph is actually adjusted for population density. And so even though, even accounting for the number of cases, you see a higher death rate in these states. And so it's really interesting, intriguing, and it really caused me to go down a rabbit hole of why. Why do we see a higher mortality rate in this region of the country and not in others? And I think it's important to understand that, and what factors really do both dictate your access to prevention as well as screening and care, and how that dictates outcomes. And so Yash is going to speak a little bit about some of the factors that can contribute to that risk.
Yeah, thank you, Alex. So actually, as Alex was mentioning earlier, this was also a reason that myself and many other members of the Ozarks team selected this route. It's because cancer disproportionately affects that region of the United States that we were traveling through. And we thought that we would have a very large impact biking through those regions. So we know that cancer disparities are known to reflect an interplay of socioeconomic factors like culture, diet, stress, environment, and biology as well. So there are a lot of studies that have indicated that individuals with lower educational levels often have higher cancer mortality rates in comparison to their more educated counterparts. There are also a lot of inescapable environmental determinants, such as proximity to processing plants that contaminate water, which are known to increase cancer incidence. So, for example, exposure to lead has shown to is known to cause renal, lung, and brain cancers in mice, and this has also been backed in observational studies in humans. So, Flint, Michigan, is an unfortunate example of this factor. There are also higher rates of colorectal, lung, and cervical cancers in the rural Appalachian regions of Ohio in comparison to the wealthier and more populated areas of the state. So this also reflects a kind of geographic disparity and a wealth-based disparity, socioeconomic disparity in cancer care and cancer incidence. And as Alex was mentioning earlier, as a result of the higher rates of cancer incidence along the Southeast United States, the region is dubbed the Cancer Belt. But we also see disparities in cancer incidence, cancer care, and cancer survival rates throughout various occupations. So industries such as fishing, agriculture, manufacturing, trucking, construction, steel, coal, and textile, so unfortunately very low paying jobs, involve higher exposure to cancer risk factors such as asbestos, benzene, fossil fuels, and other carcinogens, which is another reason we see those living in lower socioeconomic areas and those of a lower socioeconomic status having higher rates of cancer incidence, a higher risk of cancer mortality. I think we can move on to the next slide. So environment and income are not the only known factors that dictate outcome in cancer. There are a lot of studies indicating that members of minority, racial, and ethnic groups in the United States are more likely to be poor and medically underserved, so they're going to have little or no access to effective healthcare as a result, compared to their white counterparts. And this limited access to quality healthcare is a major contributor to cancer care disparities. So, for example, regardless of racial or ethnic background, the poor and medically underserved are less likely to receive recommended cancer screening tests than those who are medically well-served. They're also more likely to be diagnosed with late-stage cancer that might have been treated more effectively if diagnosed earlier. Cancer disparities also reflect differences in clinical trial participation. So clinical trials often have low participation by racial or ethnic minorities, and this raises the possibility that the results might not be fully applicable to them. So in fact, medical research in the United States is oftentimes skewed such that medications that are developed for white men do not always work as well or as intended in women and ethnic minorities. And we see that the way research works or medical research works is that oftentimes the medications and the research is skewed in favor of, is skewed in favor of white males. And as a result, there are large disparities in medical care for ethnic minorities and for women. So not only is there a greater incidence and mortality rate of cancer in marginalized communities, but they also struggle to access both treatment and preventative care. And as we talked about last week, these communities have been historically abused by the healthcare system.
Right, and so given this inequity, you may find yourself asking, how can we address this? What's the best way to address this? And I think that is a really difficult question to access. And there's a lot of different ways to do it. Just to give some context as to what the National Cancer Institute is attempting to do, is to kind of incorporate minorities into these clinical trials as well as women. It's really important, as Yash was saying, to conduct research such that, in clinical trials, medical research, such that we know how it's going to behave in the participants of that study. And beyond that, it's important to recruit from and kind of foster trust in minority groups and diverse populations, and to recruit representation in in that scientific community as well. And so there are a lot of ways we can go about this, and we'll talk a little bit more on how it works now and different thoughts on how this can be addressed. But a big part of it is understanding the nuts and bolts, putting more work into really elucidating and understanding how these things exist, how race and ethnicity and gender play a role in how individuals interact with healthcare providers, as well as those resources that allow for prevention and screening. Right, and so next slide.
So speaking on prevention and screening specifically, in addition to living a healthy lifestyle, it is extremely important that we get routinely screened for cancer, because cancers are often easily treatable if they're caught early enough. So a lot of experts recommend self-screening or going to your personal care providers in order to access some more concrete, more accurate screening. And it's important to do this on a regular basis so that you can detect cancer at early stages and severely increase your survival chances. The Center for Disease Control recommends regular screenings for breast, cervical, colorectal, and lung cancer specifically. So screenings for breast cancers include like mammograms and MRIs, and recommendations indicate that women who are above the age of 50 should get a mammogram screening every 2 years. The Pap smear and HPV tests are used to screen for cervical cancer. So these tests are usually done every 3 to 5 years, usually starting at the age of 21. Common screening procedures for colorectal cancer are stool tests and colonoscopies, and it is recommended that you begin these screenings at the age of 50. As far as lung cancer goes, the main screening is a low-dose CT scan, and if you are or ever were a heavy smoker, it's recommended that you get screened for lung cancer yearly. And you can usually get these services at your local healthcare providers. Although cancer screenings are becoming more widespread, they are oftentimes extremely expensive and not always available. But there are resources to help you with that. So resources such as CDC's National Breast and Cervical Cancer Early Detection Program provide breast and cervical cancer screenings and diagnostic services to low-income, uninsured, and underinsured women across the United States. Medicare also helps pay for colorectal cancer screening for people who are 50 years or older. So as far as treatment goes, like cancer screenings, cancer treatment can be shockingly expensive. But again, there are resources to help with that. So the Cancer Financial Assistance Coalition is a group of national organizations that provide financial help to patients. So the CFAC provides a searchable database of these financial resources. But our next speaker, Arianna Anaya, she's going to share a little bit more about local programs or resources in our community that can work towards making cancer care and treatment more accessible and more affordable.
Right, well, thank you for that. Ross, do you mind throwing up our writers again, just so we can say hi? See how they're doing on their ride? Yeah, well, thank you, Carol. That's wonderful to hear from you, writing for you today. Right, and so just a reminder that our writers are writing in honor of all of the ride dedications that you make today. Thank you for tuning in and for listening to us talk about something that we are very passionate about as an organization and as teammates. Really excited to introduce our next speaker, Arianna Anaya. I know we've mentioned her a few times. Really, really grateful to have her here today. She is the programs manager at the Foundation's Communities Prosper Center. And so she is able to work with patients working on enrollment and advocacy services specific to marketplace plans, assisting people and clients that are living with cancer, connecting them to care, which is truly a unique and incredibly valuable perspective. I'm very excited to hear you talk. So I'll pull you on screen now.
Hi, thank you guys so much for having me. Alex, I really appreciate this opportunity, and I want to thank you all for participating and doing what you do. I have probably an overly long presentation with too many slides. I will go through some of those quickly in the hopes of ensuring we can get through it all and leave time for questions. But I think most important, I will leave you all with my contact information. So if there are questions that I can answer, I'm happy to do that. Okay. So today I'm going to be talking you all through sort of the post-Affordable Care Act landscape when it comes to health coverage, but also considering different disparities and how the Affordable Care Act has impacted those. Next slide, please. Information on me is laid out there. Looks a little funnily formatted, but you can, of course, email me. You can contact my program also by email or by calling us and leaving a message. Next slide, please. My focus and my expertise will be on the Affordable Care Act for a variety of reasons. We'll talk a little bit about the provisions and objectives of the law. And I'll also give a sense of how the financial assistance works with the Affordable Care Act and what opportunities look like for someone who is uninsured to get insured year-round. I will also be addressing some of the other healthcare options that individuals might be eligible. Again, all of this information comes from resources and education my program regularly covers. So if I go through something too swiftly, we will have time for questions and answers towards the end. But additionally, I'm happy to be in touch with anyone with additional questions about any of these topics. Next slide, please. I'm starting with sort of a very, very depressing model of healthcare in this country. As I'm sure most people engaged in these efforts and work is aware, we do have a system that is predicated on profit as opposed to care in many respects. And this is intensely problematic for individuals. I think the model that we are unfortunately very accustomed to is an uninsured individual who is not receiving regular care, as Alex was just describing. And what this tends to mean is that this person will not be receiving treatment regularly, but will likely receive their first treatment in an ER. Then, obviously, because getting your care in an emergency room is very expensive, this individual won't be able to afford for the cost of that care and that visit. And so the cost will get shifted, typically from the individual back towards the provider, who then will typically shift that cost back to the insurers that they are in network with, which is what has, since health insurance exists, caused the yearly increase in the costs of health insurance, at which point in time we see individuals less able to afford their health insurance. And then we again enter this cycle where a person is uninsured. Next slide, please. So I pulled up different demographic information connected to how we see certain disparities in coverage, specifically when it comes to individuals responsible for large medical bills. And again, the cause of this tends to be a lack of access to regular care that results in someone receiving care that is a medical emergency and that is much more expensive. I believe if you go forward a slide, it will highlight the fact that, with a 25% total of individual households polled here, you can see that this is a much higher issue for Black and Hispanic individuals, that they are higher than average when it comes to these medical bills. I'll also call attention to the fact, normally that would be highlighting South, yes, that Southern areas, which, as you saw in the slides that Alex shared earlier, tend to have a higher rate of death connected to cancer, also tend to have a higher rate of individuals who report issues with being able to cover their medical bills. Next slide, please. So to put us all on the same page about the Affordable Care Act, there are certain pieces of the ACA that have been exceedingly beneficial to individuals living with complex medical needs such as cancer. Those provisions include guaranteed issue. This means that insurance companies cannot pick and choose who they sell insurance to, Prior to the passage of the ACA, a private health insurance company could essentially require someone seeking health insurance to fill out an application and could make a decision not to cover them if they had major medical needs or a history of cancer, for example, or if they were living with HIV. So that is no longer allowed under the Affordable Care Act. Insurers are required to cover people regardless of their medical needs, and they cannot be charged more on that basis. The ACA also created minimum standards of coverage and care. It also created financial assistance for low-income households, which I'll show you guys in a bit. And then it created the health insurance exchanges, which are essentially online platforms through which individuals can compare plans that must meet these standards. So it theoretically simplifies the process, the enormous and challenging process of looking at and considering different coverage options by putting them in one space. Different states opted to build their own exchanges, their own portals, but many states simply use the federal marketplace, which is healthcare.gov, and the marketplace plans, which I will be discussing because, of course, I am in Texas and we have the marketplace here. The ACA also created the individual mandate, one of the least popular parts of the law, which requires individuals above a certain income to have coverage or pay a fine, and it expanded Medicaid. I've asterisked those two because at this point in time, the mandate has been reduced to zero, and we'll talk about some of the challenges and consequences of that. And Medicaid expansion ultimately did not happen across every state in the United States. Next slide, please. So a key objective of the ACA that I think is sometimes forgotten about had to do with narrowing many of the racial and ethnic disparities in health insurance. And you can see that this has happened with the Affordable Care Act. I do think it's important to note that there has been sort of a drop-off in how successful we have seen these disparities narrowed since 2016. And this, again, is because we have had a change in terms of the administration. We've gone from one that was very, very much into promoting the Affordable Care Act to one that is quite hostile to it. So you will notice that around 2016, the gains made have sort of started to stagnate, but still, these are not insubstantial. And if you go to the next slide, please, we can see a breakdown based on certain race and ethnicities, how we've seen a overall 8% decrease in uninsured rates since the passage of the ACA, which is really quite an incredible accomplishment, all things considered. But you can also see the individual breakdown by the categories of white, Black, and Hispanic individuals. And these are impressive, impressive stats that are not enough, but they were a very important first step. Next slide, please. So marketplace plans are plans regulated by the Affordable Care Act. They're plans that are required to meet what's called the minimum value standard and to cover the 10 essential benefits. They are also eligible for affordable assistance created through the Affordable Care Act. Next slide, please. The 10 essential benefits, which the Affordable Care Act requires plans to cover, and again, these are plans that are regulated through the Affordable Care Act. Not all insurance plans in existence are required to meet these standards. But this kind of lays out major categories of coverage and care that insurance plans no longer can opt out of covering. Again, this is presuming they meet the standards of the Affordable Care Act, because not all insurances do. But two things I really do want to highlight here is mental health, something that, in our country, I think there's been a very problematic history of, and that often can cause huge disparities, considering the stigma that may be applied. A bit lower on, you can see things like prescription drugs, which obviously can be tremendously expensive for individuals living with cancer, but also individuals living with HIV, another group that has been tremendously benefited by the ACA. So this list, I would say, kind of gives you a sense of the ways in which plans have been required to offer a sort of comprehensive level of coverage and care. Next slide, please. To provide kind of an overview of who is eligible for marketplace plans and those benefits, in the left column, I've given an overview of individuals who are simply not eligible for the marketplace in general. This is how the law was written. It definitely does not mean that coverage is universal in this country by any measure. That is still a fight that we have a long ways to go with, but I do think it is helpful for these populations to know who is and isn't eligible, so people have good expectations connected to what they will be able to do. On the right-hand column are the criteria connected to those eligible for financial assistance through the marketplace. The two first pieces of criteria being they cannot be eligible for other qualified health coverage. So an individual who has coverage through their job that meets the standards is often not going to be eligible for marketplace financial assistance. That individual needs to commit to filing taxes in the manners required of them for the year they're receiving the assistance. They cannot be married filing separately, and they have to be eligible to file taxes as their own tax household. And then finally, there is a kind of income range in which an individual is eligible for the financial assistance. And you can see that for a household of one, this graph is a little strange, but looking at that left-hand column, a person in Texas would need to have an income of at least $12,490 to begin qualifying financial help. And they would stop qualifying for financial help at $49,960. So within that range, an individual would be eligible for the financial assistance. Next slide, please. So there are two types of financial assistances that the ACA makes available. The first is the premium tax credit. You're eligible for this as long as you're between 100 and 400% of the federal poverty level. And again, no one needs to learn this stuff. This is for people such as me who do this enrollment work. But the far left-hand column is the household number. So you can see that 100% of the federal poverty level varies depending on how many people are in your household. So the income amounts increase with more individuals. Next slide, please. To give a sense of how this would work, how the premium tax credit would function, if we had our pretend enrollee, Jane. Jane is 34 years old. We're going to say she has an income of about $20,000 annually. She's going to pick a plan that would cost $424 a month. However, based on her age and her income, she's going to be eligible for a premium tax credit on the marketplace. That amount would be $357 a month. And so it means her cost goes from being $424 to $67 a month. So this is how we see the health insurance itself being made affordable. Next slide. Oh, I think you went, yes, beautiful, thank you. So something that might jump out at y'all is, why is there this minimum amount at which people are eligible for financial assistance? That seems very problematic, and it is. So what was supposed to happen is Medicaid, it was supposed to be expanded to cover low-income individuals. But in states such as Texas, unfortunately, a decision was made not to make that expansion, which means we have created a gap in terms of eligibility for coverage and care in this state, where you can actually be at too low of an income to qualify for financial assistance, which is obviously very counterintuitive to what one would think of for means-tested financial assistance, right? The lower the income, in theory, the more assistance you should be eligible for. But that has not happened in certain states. Next slide. We can see that this has had a big impact on our disparities. I shared earlier with y'all the slides that show the changes in uninsured rates for white, Black, and Hispanic individuals, and that's that graph in the top right-hand side. But what you can see is there's a big difference if an individual is in an expansion state versus a non-expansion state, which is shown there in the bottom, that those changes have definitely not been as large in non-expansion states because of this gap. Next slide, please. Additionally, I think calling back to the information Alex already shared, we can see that while the states that did not expand Medicaid tend to be some of those states in that cancer belt, one big challenge for us to consider is these disparities, they are geographical, but those geographics in this country have very, very specific potential outcomes for individuals connected to race, ethnicity, and income. And you can see that the states where we have more African Americans are states that chose not to expand Medicaid. And this means fewer individuals insured and fewer individuals protected. Next slide, please. The second financial assistance the ACA creates is called cost sharing reductions. And this is actually going to reduce the cost of care. There's a narrower income threshold for eligibility here, which you can see household of one would be between $12,490 and $31,225 as an annual income estimate. The client's range is going to determine how much financial help they get. Next slide, please, which I'll show right now. So Jane, our 34-year-old who estimated an income of $20,000 without cost sharing reductions, next slide, she would be responsible for a deductible of $7,000. This is very expensive. So it means her deductible, her out-of-pocket max, her worst case scenario numbers, if she's diagnosed with cancer, we can pretty much assume that's going to have a $7,000 price tag. However, because Jane has a marketplace plan and signed up for cost sharing reductions, next slide, her income puts her in that middle bracket, that 18 to 24 bracket. And so because of that, instead of a $7,000 cost, her costs wind up being reduced to just under $2,000 in terms of her worst case scenario. If she needs chemotherapy, she's going to pay her specialty copay, which with that income bracket winds up being $5 as opposed to $80. This is a big deal when your income is $20,000 a year. That's going to make a difference between this person's ability to continue to receive their chemotherapy or their infusions if they have cancer. And again, if there are costs beyond that, if she needs surgery, if she needs radiation, you can see that a price tag of $1,950 is obviously tremendously more manageable for this individual than that $7,350. Next slide, please. Again, I'm zeroing in on what her costs would theoretically wind up being. Her copays wind up being much lower just for regular treatment and care. In fact, for primary visits, that becomes a pre-visit, which again, could be one of the first steps in getting someone who is at risk into being screened and potentially catching cancer before it is a diagnosis that is obviously more costly, but also more challenging to battle. Next slide, please. Here I've described a little bit what deductible and out-of-pocket mean. With this specific plan, her deductible and her out-of-pocket max are the same, but generally speaking, a deductible is what you pay before the health insurance kicks on and begins sharing those costs, whereas the max is when your costs end. So again, if she's hit her deductible with this plan, she will have hit her max. And at that point, the health insurance is responsible for paying 100% of the costs of her care for that calendar year. And again, knowing what we know about those costs potentially be in the hundreds of thousands, a $1,950 price tag is a low price tag, unfortunately, when it comes to cancer care. And speaking from our experience working with different oncology organizations, there is much funding available to assist with that. That is a doable cost when it comes to a diagnosis. Next slide, please. I do again want to reiterate that insurance companies no longer have the ability to treat an individual with a specific diagnosis differently, that the ACA in offering these guarantees has kind of changed the notion that a person with a medical need is somehow different or deserves stigmatization by standardizing what health insurance care looks like and covers. Next slide. I will be very honest that we are obviously experiencing quite a good number of challenges to the Affordable Care Act and those it protects. We have a constitutional lawsuit pending, Section 1557, which the Obama administration had interpreted as extending civil rights to transgender individuals and individuals who had sought or had abortions, has recently been sort of reinterpreted by the administration, kind of in theory providing providers with a sort of license to discriminate, which is really sort of an ugly thing to happen, especially during a health crisis, as though we don't have bigger things to worry about. Public charge has made immigrants much more afraid to access the benefits that I've been describing, though I do want to state, if you are aware of an individual concerned about public charge and how it may impact their health coverage eligibility, please connect them with our program, because that piece of legislation has been massively understood and utilized to terrify our immigrant community. And we want to make sure they have accurate information. The end of the mandate, so the fact that there is no longer a fine for being uninsured, has caused a lot of confusion. Individuals have understood the end of the mandate as the end of the Affordable Care Act, which is not correct. And this has also allowed for the rollout of a lot of short-term skinny plans that do not offer the benefits and the guarantees of the ACA. And we are seeing many people sign up for those when they learn of a diagnosis and then coming to find that those do not cover their needs. And then lastly, we have very limited enrollment opportunities. Next slide, please. Generally speaking, individuals can only enroll during November 15th to December 15th, the open enrollment period. Without that, they need to have what's called a life change event. And as much as a cancer diagnosis or a new unknown emergent need seems like a life change event, insurance companies do not want people to sign up connected to a medical need. So that is in fact not a life change event. Next slide. I've listed out some of the general year-round events. You can see that these are very specific. Next slide, please. But I also wanted to provide specific events that the COVID-19 crisis has kind of triggered, which is loss of coverage. So if your job coverage ends, or changes to income. These two are frequently events that a new diagnosis of cancer may cause. So again, it is not a diagnosis of cancer that enables you to sign up for coverage, but rather some of the factors surrounding that diagnosis may offer you that event. Next slide. COBRA is something that I think can cause a lot of confusion for a client who has been diagnosed and doesn't know whether they should take it or not. And I think the most important piece here is that everyone's circumstance is different, and it's important to compare your COBRA option to the expenses of a marketplace option, because COBRA can be very pricey. Sometimes COBRA is the better way to go, but a good idea is to seek out support from someone who can assist you with comparing those options. Next slide. We do have CHIP and Medicaid, mostly for children in Texas, because again, Texas did not expand Medicaid to cover low-income adults. But it is good to be aware that there is Medicaid for breast and cervical cancer for individuals up to 200% of the federal poverty level. And then very, very low-income parents are sometimes eligible, but they need to have next to no income in Texas to apply. But it's good to be aware of these things. Next slide. Finally, generally speaking, I always recommend that individuals seeking a program to cover the cost of their cancer care contact 211, which is how to connect to the United Way, to learn more about their local county healthcare programs. An example for us in Travis County is MAP, which is unusually robust and can offer access to cancer treatment for those eligible, but that is not very usual for a county program. And then, of course, federally qualified health centers, which are required to cover the uninsured, but typically their services tend to be primary. And so if someone needs specialty care, that may not be a great fit, but it is important for individuals to be aware that these organizations exist and that there is a way to receive primary care, even if you are uninsured. Next slide. That is it. I worry I've gone on too long. I think one more slide. There are a couple more resources listed. Please feel free to email me or contact our program with any questions you may have.
Awesome. Thank you so much for that talk, Arianna. I learned so much. And I do feel that you explained all these things so clearly, and I'm grateful for the resources and for your time. If we have any audience questions, then we can try and answer those to best of our ability. I do have a question I'd like to start us off with, if you don't mind. I was wondering if you could talk a little bit about your experience working with patients, and if you have any particular stories of patients you've worked with that come to mind.
So many. I think the biggest, honestly, working with cancer patients and patients living with HIV for me has been the most most valuable. God, it kind of makes me emotional. Piece of the ACA. It's just kind of unbelievable, the changes. And I was contacted by a navigator with one of our local oncology sites asking me to reach out to a gentleman in Bastrop County who had a very serious cancer diagnosis, who wasn't interested in looking into health insurance care because it was too expensive, right? Which is true. Health insurance is expensive. I called this gentleman every day for like 3 weeks. He was a very ornery fellow. He would yell at me and say, like, I can't afford health insurance. What are you even talking to me about? And he looked at me and he was very upset. In many respects, totally correct, right? Like what he was saying was true of health insurance just 2 years before I had reached out to him. And then finally, I would just listen to him rant or just listen to him get very mad. And I finally talked him into like letting me show him plan costs. And I was able to show him a plan cost that was like $5 a month. And his max out of pocket was going to be something like $800, which would cover the cost of his surgery. It would cover like everything. And I like showed him this, and he kind of took a breath. He's like, ma'am, I might owe you an apology. It was just, I don't know. We get such moments like that where people really talk about the work we do as life-saving and incredible. And I think it's just so, I so appreciate that, but that's what we should be doing, right? Like this is the tip of the iceberg. There should be so much more happening for this population. And it's such an honor and privilege to impact in the small way I am able to when it comes to funding. But the challenge is people have so much stress and concern with a diagnosis, and why wouldn't they? And the insurance and the bureaucracy piece is overwhelming. And that's why I'm like, come to us. Let us take that off you, because that's one teeny thing that we can do. So it's such a privilege to be able to do this work, but Texas doesn't make it easy.
Certainly. And it's, I think, something that, I certainly wasn't aware to the extent of what an impact you're able to make in the lives of these patients. And I think that a lot of patients are just completely unaware of those resources that they have to be able to access care. And so I'm very grateful for you. I think I feel similarly about epidemiologists, people working kind of within the healthcare system that don't get the kind of praise that other healthcare workers get. They're like the silent superheroes of healthcare that make this possible. And that is truly, truly amazing. Very, very grateful for the role you play in connecting people to healthcare. You are amazing. Do we have any audience questions? No, just praise. Certainly, I know that, I myself learned quite a bit, and I'm very grateful. Yash, do you have a question?
Yeah, I have a quick question. So how can we better get involved with foundation communities, and how can we better help support the mission of foundation communities?
Oh man, I would say, so foundation communities has sort of a very large scope. We're kind of a huge organization in Austin. So they start with affordable housing, in fact, in the Austin area, which is quite a challenge because Austin has changed. And, speaking of health disparities, the gentrification of the city is really quite a challenge to cope with. And we're seeing the residents pushed out of the city. But from there, we have a very financial stability sort of mission and vision for our families and for our community. And I think as much as possible, get the word out that this type of financial assistance is available. We right now, especially during COVID-19, all of our services, including tax preparation, financial coaching, job hunt assistance, these are all things available by phone. And it's funny because it's very hard, I think, to get most people sort of excited about financial coaching. We all know we need it, right? But nobody's like, yes, sign me up. I want to do that. But
Sounds thrilling.
yeah, but right now more than ever, you know, a crisis budget is a real thing that I had never heard of. And there are individual members of our community right now who would never think of themselves as at risk. And so many people are, and they just, there's insecurity and there's all different kinds of reasons that people don't reach out to learn more. And that's what I think, you know, the hope is that with health coverage, with financial security, people need to get in touch with us because there's just so much available and we want to do that work for our community. Like, this is our community. So I think as much as people who are interested in this want more information, please reach out to me. We will do any presentations and do whatever we can to help the community during these times.
Well, thank you so much. We're a little bit behind time, so we're gonna have to move on to our next. Oh no, thank you guys. Very much enjoying every part of that. So no worries.
Thank you.
And thank you for your candid answers as well. We're gonna move on to our next part. We get to speak to two of our teammates. Claire will help lead a conversation with Anna and Nikki just on their experiences of navigating healthcare for their loved ones as caregivers. Very excited to hear from you guys.
Yeah. Hey, everyone. So thank you so much, Nikki and Anna L, for sharing your experiences with us today. And very quickly, I just want to encourage anybody who's watching to comment any questions you may have for any one of us as we converse. So Nikki, I want to start out with you. Could you share a little bit about your experience with cancer and as a caregiver, and eventually what drew you to Texas 4000?
Yeah, so my experience as a caregiver has spanned over 10 years, with responsibility just increasing as I grew older. It's been really emotionally taxing, but also rewarding. And my family is just the most important people in my life. They're why I joined Texas 4000. But during her initial surgeries, simple actions like lifting a backpack, bending her toes, getting a glass of water in the middle of the night, they just became impossible. And when she went through her first 3 surgeries, we had to teach her how to walk again and again and again. And we were just there when she took her first steps over and over. And so those moments, I would say, were really rewarding because it's not often that a younger sister teaches her older sister how to walk. But I think my sister's strength is just the reason why I joined Texas 4000. She didn't let cancer take a hold of her life, and a family friend in 2018 decided to ride for the people in her life that were affected by cancer, my sister included. And it just completely changed my perspective because I never did anything about my sister's condition. I just took it as what life afforded me. But this 2018 rider chose to do something about it and take charge of something that had affected us both. So I would say Texas 4000 was kind of the point in my life where I decided to do something about my sister's illness. But
Yeah, I'm so glad that a past writer could inspire you to do the same. And of course, everybody on this team is always looking forward to hearing updates about your sister's battle and always keeping her in mind as we're writing. And Anna L., I wanted to ask you a similar question. Could you tell us why you originally joined Texas 4000 and also share a little bit more about your experience as a caregiver?
Yeah, originally when I heard about Texas 4000, I was very inspired by its mission and the fact that we could all unite and like share stories that can motivate us to change the future of cancer. But personally, I found out that I especially ride for my mother, who is like a heavy drinker and a heavy smoker. And so I'm very well aware that these are very high risk factors for cancer. And in general, I am a big advocate for preventive care because for my own family, who we come from France and we're immigrants and we have different hurdles like language barrier, cultural barriers. That has been the biggest challenge for like motivating my parents to get regular care. And I think that every day I worry about, the risk of them, especially for my mother, who is in high risk of catching different illnesses, especially with cancer. So I think that my main motivation to be part of Texas 4000 is to kind of advocate for that, and especially advocate and educate others for prevention and the different hurdles that you can have to access like healthcare.
Yeah, and I know that these experiences not only encouraged you to join Texas 4000, but also pursue pre-med and apply to medical school. So I applaud you in that. So what did it feel like to interact with the healthcare system in the U.S. as an immigrant? And are there any hurdles that you faced while trying to advocate for your family that you can share?
Yeah, I think the main issue when you come from a entire different country is there's not only like the cultural difference, but it's just the entire different healthcare system. I mean, my family's from France, and over there you have universal healthcare coverage, and so the system is completely different. So I think that especially when my parents came here, they were kind of lost, and I think that Arianna also like kind of highlighted all the difference issues that you can come across to be like eligible to get healthcare. And I think that one of the main hurdles for us is that my father at some point lost his job, and so we weren't eligible to get insurance because we were kind of like in the middle range of eligibility. And I think that that is a big hurdle because even also if you end up having insurance, I think one of the main issues is understanding how to navigate it. I think a lot of times people forget that it's so difficult, I think, to understand all the different aspects of, insurance, of eligibility, of premiums and everything. And so I think that especially if you come from a different country, you're even new to the language, just simply that is extremely hard. So I think the work of Arianna is incredible in the sense that they can help people understand that. And I think in terms of my family, one of the biggest aspects was also mainly the language. I think that my mother is very hesitant to go to the physician because she's always scared of being misunderstood. And, it's kind of like the fear of being vulnerable as well. When I was a child, I could accompany my mom and like translate for her, but it's never the same when your own child has to kind of like translate your own like, health issues. It could be a very touchy subject. And so even now when I'm outside of the home, I'm not here to, maybe accompany my mom. So I know that that's one thing is that the motivation to go and seek care is very hard. And so oftentimes she would go as a last minute. And that can be problematic when you go and seek care only when it's an urgent issue.
Absolutely. I can't imagine how difficult it would be to go from a country with universal healthcare and then to the United States, where that is, as we know, not the case. And so, Nikki, I want to switch to you for a moment and ask if you could share about your struggles to procure your care for your sister during her battle.
Yeah, so similar to NL, my family were really lucky to already be citizens, but the one thing that we just didn't know when we moved from Dubai to the US was exactly how the system operates. And we were just completely clueless and thrown for a loop because we didn't know anything about the ACA, Medicaid, SSI, SSDI, all of that stuff. And it was only because my mom, she took a job at Foundation Communities. And that is how we found out about Medicaid. And so when we initially got the diagnosis, we didn't have health insurance, and we couldn't qualify because my sister's cancer counted as a pre-existing condition. And this is exactly what Arianna was talking about in her presentation. Because of my sister's history, even though she was diagnosed in 2009, they classified her cancer as a congenital disease. And so she was denied by a lot of insurance providers before the Affordable Care Act was passed. And so once the ACA was passed, we were able to buy insurance. But at that point, we were already 2 spinal surgeries deep. We had an expensive proton beam radiation. And our experience was that there wasn't much support for us to understand how the system navigates in a way that protected us financially. And we were lucky at the time that we had assets so we could pay off some of the debt, but that money soon ran out, and financial toxicity is a reality for a lot of cancer patients, not just my family. And I would say the main issue that my family has found the most difficult is that there isn't much support on helping families procure insurance other than businesses like foundation communities. And the referral system especially causes delays in getting treatment and MRIs, and there's not much financial counseling offered when it comes to these things other than radiation and chemo. And so in addition, there's not much support for physical therapy, which my sister desperately needs because of spinal cancer. And if she doesn't get the therapy, it leads to more issues down the line as well. But it's not classified as necessary enough for there to be ample resources. So, you know, in our case, insurance only paid for 20 sessions out of the year. There's 52 weeks in a year, and that's not enough sessions for someone that has brain and spinal cancer. There's also a lot of issues that she has with her, you know, her legs, her lower back, her arms, her chest, and her throat because of where the tumors are. And so another big issue with the referral system is that if the oncologist isn't specific enough in their orders, whether that be, you know, a referral to another doctor or for prescriptions, insurance doesn't pay for it. And so a lot of months have been wasted in my family because of this. And this is something that has been particularly frustrating for us. And so I would say that has just been the most difficult thing in regards to procuring treatment for her and just care in general.
Yeah, thank you so much for sharing all of that. I know that there are so many forms of care that cancer requires outside of just the traditional treatment forms. And so I can't imagine what it would be like to not know if these things will be covered.
Yeah.
Yeah. And so I want to switch back to Anna L for just one more question. I know you touched on this a little bit when we were speaking about your mom, but could you share a little bit about how she felt marginalized or unable to access care as an immigrant? And were there any ways you helped her overcome these hurdles?
Yeah, I think that one of the issues for my mom at some point when she came to the country is that she kind of lost her support network. She lost, she sacrificed her job, she sacrificed her friends, her family coming here, and she was coming into an entirely new area, which is the case for, of course, many immigrants here in the U.S. And although every immigrant experience is different, I think that for my mother, she suffered through some mental health issues, and the biggest hurdle is that when you're in a new country, I think it's even more difficult to take the step to ask for care, especially when I was young. She can really seek out help to her children because we were young, and so I think that big hurdle is taking the courage to ask help. And I think that the fact that she didn't even know the language it's hard to find the resources necessary when you're kind of isolated. But when I grew up, I was able to have more conversations with her. I was able to seek out the resources needed for her. And so she's doing much better. But I think that the biggest issue for me is when you have physicians and they have patients. That I think for me half the work is already done because the patient is already in your office there to ask help. I think that the other half of the work is to be able to bring that patient in the first place. And then we talked about the different barriers that can lead to that. It can be cultural, it can be financial, it can be just the lack of insurance. There's a lot of things that prevent people to ask that help. And I think that the big work that has to be done is to help give the courage and empower others to be able to seek that help. And yeah, I think that's what I'm especially motivated to help do, even in medicine.
Absolutely. I think you're right, and that the first step is just getting people to see a physician before actually being there. And so to both of you, what do you think we can do to try to address the problems of marginalization, mistrust, or cultural disconnect in cancer care specifically?
Yeah, so I think there is a lot of mistrust because cancer care isn't as holistic as it could be. I think there needs to be a bigger emphasis on diet, mental health, physical therapy, and a lot of things that patients need in order to get healthy, in order to fight the illness. But I feel like cancer care is more so focused on just treatment, so chemo, radiation, surgery. And that's just one part of it, but it makes patients feel abandoned, like they're off to fend for themselves in all these other areas of their lives. And I think patients shouldn't have to be responsible for, seeking out that information as much as like social workers at hospitals need to provide that information blatantly and just say, here are all of your options. And with us, like, we had no idea Medicaid was on the table. And that was just something that we had to look for ourselves. And so I strongly think that, with everything that we have to deal with paying treatments, physical therapy, mental health, on top of paying parking, transportation, all that stuff, I think that there needs to be a reform on what priorities need to be adjusted. I think that there needs to be reform in order to fix the mistrust from feeling marginalized due to income and a lot of other aspects such as race.
No, I truly agree with Nikki on the fact of the mistrust part. I think that a lot of the time, if you don't have the trust insurance to seek care, that's like the big hurdle to it. I think that definitely like investing more in support services that kind of as kind of Nikki says, like sees the patient as a holistic approach, that you're not just there to treat them, but like you see that their whole other aspect of their life, their family, and how they move on after their cancer even. But I think that also something that would be like that is important is also in terms of the research. I think that we even in the presentation there's lack of research for different races or different types of populations. So I think that it's extremely important that we start kind of like shifting our focus to not just one type of population, but like trying to expand care for everyone and finding the different ways in which we can do so. And even as a physician, I think it's important to take all of these aspects in mind. And as Nikki said, that you're here to also support the patient in terms of how can they access care in the future and in the long run, and not just right now. So.
Absolutely. Well, thank you so much to both of you for sharing about your experiences. I know that it's not always easy, but I think the information that Arianna shared, and then as well as hearing about personal experiences, is a really impactful way to learn about these issues. So is there anything else either of you would like to add before we close off the event?
No, I'm just thankful to be able to talk about this. I feel like this is one of the things that I haven't been able to talk much about. And so
Mhm.
I'm excited that it's happening. But yeah.
Yeah, same goes for me.
Awesome. Well, thank you guys so much. I think we're going to pull up our other co-host here. Awesome. Before we close off, so thank you so much to our guest speakers, Arianna, Nikki, and Anna L, for being here today to discuss such an important topic. We here on programs are very passionate about raising awareness of these disparities, as we think that a person's socioeconomic status and ability to pay for cancer care or their skin color should not dictate either their access to cancer care or their ultimate outcome after that care. And so we're grateful we're able to converse about these topics with people who are a bit more informed and like Arianna, as well as have lived through these things personally and engage our audiences virtually. So thank you all so much for tuning in with us. And lastly, we invite you to join us this Thursday on June 25th at 6 p.m. for our final event of this series, where we'll be touching on how COVID-19 has affected cancer treatment for many of those who are battling right now. Awesome. Thank you.